avoided. And as we already discussed, it is a reason for one of the common causes for non-traumatic joint amputations worldwide. So, it's usually a long journey from callosity to amputation. So usually it begins as a dryness of the feet, during which patient will develop a small callus or a broken cracked feet. Later, which will become a painful blister and then an infective ulcer. Then, which will slowly progress over years to gangrene, myomectosis, finally ending in a catastrophe that is amputation. So, we can avoid this catastrophe if we intervene early. So, why managing a diabetic ulcer is very difficult because it is stubborn and it is strong refusal to heal in spite of our sincere efforts and antibiotics. And usually, it will be, even if it heals, there will be early recurrence even after surgical intervention. And then there is always this high risk of infection in diabetes. Then poor patient awareness and late presentation because people often ignore this dry feet and callus. So we all know the triad behind the diabetic foot, which involve ischemic foot, neuropathy, and stiffness, that is limited joint mobility. So we all know that diabetes affect our sensory, motor, as well as the autonomic nervous system. So all this neuropathy and diabetes, what it causes to our foot, we lose all our small fat pads and muscles go for paralysis or shortening, and the joints loses suppleness and mobility. So all the bones and become prominent, and the pressure points shift to abnormal points where we develop callus, and the callus breaks open to form ulcer, which will get infect the underlying structures, leading to myonecrosis, amputation, gangrene. So why this ulcers take a long journey? Why it goes unnoticed? Because it has no pain and the progression is very slow. And then loss of pain, pressure, temperature, and sensation. So most of the time the injury goes unnoticed. It takes even weeks for the patient to notice that there is an ulcer in the feet. And minor trauma is not felt by the patient because of the neuropathy. Then repetitive stress, it damages the skin. And most common initiating factor for diabetic foot ulcer is this repeated stress over the injured sites. So we follow the classification for diabetic foot. So class 1 is no ulcer or pre-ulcerative stages. So there will be only a callus. So whenever there is a callus, below the callus there will be an ulcer. So that is stage 2, ulcerated foot or a superficial uncomplicated ulcer. Then we get class 3. Here the infection becomes serious. It invades the underlying structures. It could be the tendon, bone, muscles. The foot becomes crippled. So most of the patients come to us in this class 3 or class 4. So class 4 is the catastrophe, that is the critical 4, where the patient present very late with gangrene, loss of vascularity, or extensive tissue necrosis, where we have to go only for amputation. So this is class 1. If you see, the feet only has callus, which is very treatable, but most of the patients ignore this stage. Then they come in class 2, where it becomes uncomplicated and superficial ulcer. But here the deeper structures are not at involved, so even at this stage we can prevent the catastrophe. Then class 3. So this is how we get most of the patient. So from a small ulcer in the wall of the great toe, we all know like it spreads along the flexor tendons in the foot. So it has ascended proximally. So where we have to go for a radical extensive debridement to remove all the tendons and soft tissue. It needs reconstruction. So once the reconstruction is complete, then we have to go for offloading. So this is class 4 where the vascular compromise is there and extensive tissue necrosis has happened. So the thing is, from all this class we understand that amputation doesn't happen suddenly. It evolves over a period of time. It goes unnoticed and ends up in amputation. It doesn't happen overnight. So why do we have to stage diabetic foot ulcers? Because it helps us to guide the line of management and to explain the prognosis to the patient. So who are all the ideal candidates for surgery? When I talk about surgery, I mean offloading. So that is surgical offloading. So it will not help patient if when they present with class 3 or class 4. So only patients with class 1 and class 2, that is patients with pre-ulcerative changes and failed conservative measures and then early uncomplicated ulcers. They are the ideal candidates for surgical offloading. So pedobarogram, because we can offload the foot either surgically or by external devices. Why all this callus and ulcer happens? It is all because of the changed plantar pressures. So to treat this ulcer, we should treat the pressure, not the ulcer as such. So to know what is happening in the diabetic foot, we should know how the pressure is distributed in the foot. So that's why we go for pedobarogram. Pedobarogram is nothing but it's a plantar pressure map. We map the abnormal pressure points so that we can know where the future ulcers are going to develop and we can prevent it. So usually pedobarogram is done during it is in static as well as dynamic way. That is while standing as well as during walking. So whenever we get a red zones are at risk for ulcer. So we are basically treating the pressure, not the ulcer. So whenever we look at an ulcer, what we should think in our mind is so from where the pressure is happening. We are not looking at the ulcer, we are looking at some abnormal pressure point. So after a pedobarogram, we will give them a prescription footwear. So these are the different footwears which we prescribe. So if you see the forefoot footwear, it is mainly to offload the forefoot. That is to avoid pressure in the forefoot, which is given mainly for metatarsal ulcers. Then we have hindfoot shoes, which offloads the heel, mainly for heel ulcers. Then one of the most common diabetic foot we encounter is Charcot's foot. So for that we give double rocker footwear. So this is a clinical image of Charcot's foot and had pedobarogram and for which we have prescribed a double rocker footwear. So Charcot's foot is complete failure of the biomechanics of the foot. So which is very difficult to treat. So it is a complete failure, whereas in class 1, class 2 it is just altered biomechanics of the foot. So by giving this prescription footwear, so we are customizing the footwear and we are offloading the pressure and we are trying to relieve the pressure points. So this is how a double rocker footwear works. So it accommodates and absorbs the plantar midfoot forces. So that's why it gives time for the midfoot ulcers to heal. So this is a pedobarogram of a patient with heel ulcer. So we are offloading the hind foot here. So management, as I already told, for class 1, we can go for conservative measures. We can suggest some appropriate footwear as well as supportive measures. Supportive measures include appropriate foot care, which we often fail to explain to the patients, which we will see in detail later. For class 2 are the ideal candidates for surgical offloading. Class 3, when the patient presents with sepsis, with weak ulcers, then we have to go for a radical debridement, which will definitely require a reconstruction in the form of flap or skin graft, followed by surgical offloading once the wound settles. Class 4 will always end up in major amputation. So mainly we focus on whenever we treat diabetic ulcer, our focus is on mainly reducing the plantar pressures and to promote healing. And one more point is to prevent recurrence. So offloading, whenever we talk about offloading, we have external as well as internal offloading. So external offloading is mainly by giving customized footwear. So this is the gold standard for any ulcer management. So effective pressure relief should be done. We usually prescribe two pairs of footwear to the patients, one to be worn inside the house and one whenever they go out. And these footwear has to be changed every 6 months. The pedobaramam has to be done every 6 months because all this biomechanics will keep on changing, will keep on altering. So we have to find out the new pressure points and offload then and there so that the patient doesn't develop life-threatening ulcers and infections. So it redistributes all this customized food, but they help to redistribute the load across the entire weight bearing surface of the foot. So we don't get pressure on one point and it end up in callus. So we have so many methods other than this, which is total contact cast and on the one which we discussed and elaborated right now, that's prescription footwear. But the problem is it requires a high degree of compliance from the patient because whenever I prescribe such footwear to the patient, the main complaint will be it becomes a social stigma, like it doesn't look like a normal footwear. They think like the foot has ulcers, so the compliance is very poor. So one more method is internal offloading. That is we introduce surgically, and so the aims of surgical offloading is the same. We to dissipate the pressure throughout the weight-bearing surface of the foot, to restore mobility of the stiff joints, and to correct the posture and to correct the deformities. So the main thing is to preserve the maximum contact surface of the foot. And one more thing which is often ignored or which is not often emphasized much is the skin care. Because not only the nerves die, but also the skin also fails along with it. Because of the autonomic neuropathy, there is no sweating, so it ends up in xerosis or extensive dryness, which ends up in cracked feet and callus. So whenever there is a small skin breakage, it becomes a portal for severe infection. So all these ulcers start from neglected dry skin or cracked feet. So what can we do for this? So usually I tell my patients like once you get diabetes, whether it is under control or not, how you treat a baby skin. If that kind of similar skincare should be given to a patient with diabetes. We should daily give a good moisturizer as well as daily food inspection. So we should train them to look for cracks, redness, callus, blisters, discoloration every night before they go to sleep. If they can't see, they can't protect their feet. So washing the feet, they should wash once or twice daily using mild soap and soaking in hot water, taking a salute pedicure is not at all advisable because soaking in hot water, the one thing is they have already sensory neuropathy which will result in burns and prolonged periods of soaking will cause maceration and further infection. So, what kind of moisturizers? We have a lot of parabens and calamine lotions, but they are not sufficient for diabetic feet. We should go for urea-based creams, especially 10 to 20 percentage concentration, and it should be applied twice daily, which will control the dryness and cracked feet. So, prevention is the best reconstruction we can offer to our patients, and emollients and those things should be applied over the entire plantar surface of the feet. That's what we should instruct our patients particularly, and it should be avoided between the toes because the interdigital spaces they will harbor already infection and minor ulcers. So adding a cream there will macerate it further and result in severe infection. So whenever a crack is not responding to our conservative treatment, even a deep crack should be sent for referral and proper surgical intervention because a crack today is an ulcer tomorrow. So all callus are pressure markers, and we shouldn't encourage them to go, to use a blade or nail cutter to remove the callus. and all this chemical corn removers and corn caps which are available commercially in the medical shops. It should be always prepared by a professional, and food bag collection is a must. So same nail and interdigital care. The nail should be always trimmed, and any fungal infection in the nail, that is onychomycosis, should be controlled with proper nail lactose.